Hello, this is Cindy Kraft and Dee Cornetti, and we are very glad to be here for part 3 of our ongoing discussion about everybody's favorite topic, documentation. We spent part 1 talking about the ABCs and the nuts and bolts of what needs to be in quality documentation. In part 2, we took a bit of a different slant by looking at some of those bigger issues around the conditions of participation in particular, and how well do we demonstrate care coordination and those types of things in our content. In this part, we're going to take a little bit different slant. Some of the topic areas or definitions may feel familiar to you if you were in parts 1 and 2, but we really want to talk about what are some strategies about finding these elements in documentation from the vantage point that more doesn't necessarily mean better in this particular topic area. I'm sure we've all read long descriptions or long narrative paragraphs that left us scratching our head going, I still don't understand what's going on with this patient. One of my personal amusements, I guess, is when we read this long-winded, entered the home and walked into the living room and patient was seated on the couch and the cat was in the window, and you kind of go, okay, I have a visual, but none of this speaks to skilled, reasonable, and necessary, and this is not about care coordination. So although it's interesting, why would we spend time on things that don't really hit those key points? We don't like documentation anyway. How do we ensure that we're doing it the most efficient and effective way possible? As someone who reviews, either you review your own, you're reviewing peers in a peer review situation, or maybe it is part or all of your job responsibility to audit documentation. I have a special soft spot for you, in particular that last group, because sometimes we end up in a very adversarial situation, as if the reviewer is the police, the documentation police that just comes out to tell me when I'm wrong. What we want to build upon is a structure of positivity where reviewers and reviewees are seeing each other on the same page and not in different camps. We have our objectives here on the slide and in your handout. You can read those. We don't need to read those for you. And I just want to remind you before we start talking content that if you have any questions or comments or things you'd like clarified about today's content, please go ahead and put that into the Q&A box, not the chat box, the Q&A box. Dee and I monitor those respectively during the presentation, and we'll interject those as needed. If we're not able to get them during the content, we do save time there at the end to catch up on anything we may have missed. So please feel free to use that at any moment the mood strikes you. You don't have to hold your thought to the end. And we welcome interaction. For those of you listening to the recorded version who say, well, that's interesting, but that won't work for me, you can use our email addresses that are at the end of the presentation, at the end of your handout. We're happy to field any and all questions you have about today's topic. So today's topic, why audit? Some of this might be, well, we have to, or, our agency has a policy about certain numbers of charts per quarter or per month that have to be done. Yeah, okay, but sometimes this requirement element to it, or we've recently got in trouble and now, we're auditing everything to the hilt. We're 100% reviewing all kinds of stuff because X, Y, or Z happened. The challenge, though, is not the why we audit, but what are we actually looking at? And I think that when it comes to formalized auditing, something along the lines of a pre-billing scrub, and you may call it something else, but the elements of this will probably feel familiar. When we look at it from that vantage point, it's much more of a checkbox situation. Things are either there or they're not there. So when we start looking at it in terms of our orders in place, what were the time frame on the evaluations, do we have interventions, do we see goals, all of these things we kind of look at them as an all or nothing, a black or white, is it there or is it not? Unfortunately, we've seen more than the isolated agency routinely doing internal reviews like that, and yet on external review run into some serious denial issues. Where's the gap? We've been auditing. How did we miss it? Well, sometimes what we have to really think about is, are we auditing to the quality elements as well? Are we looking for consistency between the OASIS and the therapy evaluations? Not from the how are we ensuring that the OASIS responses are accurate, but do we see harmony between these? Do we see skill? Does this make sense from acceptable standards of practice? Are we seeing evidence of clinical decision-making and individualized care planning? That last one is a big sticking point for me because as I interact with a lot of different reviewers, it is a very common statement to say, I don't really even need to look at the name of the therapist, or I don't need to know which nurse it specifically is. I can ID them by their care plan because it's pretty much always the same frequency, the same duration, very similar goals and interventions, and pretty much the same course of care. It doesn't seem to really matter what the condition of the patient is because the plan is very much the same. That needs to be more than an observation internally and really a launch point for some internal dialogue about why this is a risk. Because it's not just an anomaly. It's not just, someone just does this out of habit. This is being externally scrutinized as the quintessential cookie-cutter therapy that's not addressing issues of patient uniqueness. And we hit that hard in the conditions of participation discussion in Part 2, that this is not because Dee thinks you should do it or Cindy woke up this morning in a cranky mood and wants to talk about this. It's because we are expected to show that individualized care planning. But how do we get out of just saying, yes, I understand that, to need to do it, as we covered in Part 2, but if I'm reviewing it, how do I know I'm seeing it? Well, we always tend to look for external resources, and I think anything that comes directly from CMS we need to look at. Sometimes with a grain of salt, sometimes with a little chuckle of that really didn't make all that much sense or make it better, but it's the authoritative resource. If they're going to be the ones looking at our stuff, what are they saying? So we've seen in the Transmittal 179 really some clarifications around, in particular when we're looking at therapy, this issue of the improvement standard. CMS was forced in a court of law by virtue of a settlement in the Jimmo case to have to expand some of our regulatory language to be very clear that coverage of service does not turn on or live and die by whether or not this patient is going to improve. Improvement in and of itself cannot be a denial reason. Now, we may say, lack of improvement, that's what, whoa, just stop. What we have to really do is think bigger. It isn't just one factor about patients. Oh, they got better, therefore the service should be covered. They don't get better, we won't get paid. It's not like that. And within Transmittal 179, they did provide what they referred to as some enhanced guidance on appropriate documentation. I think part of it is a clarification that they don't consider the act of documenting skilled service. And I think that's fair. It's not a therapy-specific, tangible intervention. It is not nursing doing wound care. Documentation is not on par with that clinical vision of skilled. However, I think this statement out of Transmittal 179 is a great one for all of us to rally around in the fact that documentation is how we communicate skill. So it isn't a skill in and of itself. It doesn't constitute the skilled care, but it is how we communicate. It is really the only tool we have to communicate. I don't see us in the near future walking around with body cameras having our visits filmed. And without that, we are going to have to be able to ensure that what we're doing as part of this care is speaking to the elements of the benefit we need to address. So we have to understand that tool is vitally important. We do not see Medicare giving us copious amounts of examples. I think they do it for the same reason that Dee and I don't do it either, is there's always a risk by providing a whole litany of examples of people simply saying, aha, that must be the, quote, right way to do it, and start cut and pasting the heck out of it, and then just using the same phraseology or the same statements over and over and over again into infinity. I think that would be even bigger risk if CMS did it, because if this was Medicare's way to say it, we'd be all over it. Look what happened with homebound status. I mean, how many times can we say taxing effort? That's not a term we use in any other context, but we love to throw it in homebound because that's the word in the regulation, so I should use that word back. Well, that hasn't proven to be effective, and neither does cut and paste of examples. What we do see, though, in Transmittal 179 is a very interesting kind of backdoor way into it that says, well, we aren't going to tell you what it looks like, but we are going to tell you what we don't like so much. And three of them are very clear, and in the therapy universe, the first two, unfortunately, are very familiar. Patient-tolerated treatment well. I'm sure you're saying, wait a minute, I thought we eradicated that. I thought we stomped that out into oblivion. No one says tolerated well anymore. Well, unfortunately, yes, they do. That's not CMS making it up. Dee and I see it as well. Also, its cousin, which is the variant that says, oh, I'm not going to say patient tolerated treatment well. I know that one's not a good one. So I'm going to say patient progressing toward goals over and over and over and over again. Great. We still don't know what that progressing is. We don't know what the goals really are you're referring to. It doesn't say tolerated well, but progressing toward goals without context, beaten to death, is vague and insufficient. Continue with POC. Continue per POC. Okay. What does that really mean? And patient remains stable. Were you trying to get them stable? Was stable the intent? What is stable for them? Like, is that stable within normal? Is it stable in the context of their disease process? You can see where these little phrases are the problem. And it's not because they sit in a room and go, we hate the word patient, we hate the word tolerated. No. But it's anything that is ill-defined that gets seen over and over and over again that undermines the quality of documentation. So as a reviewer, I would say our eagle eye toward how many times am I going to see that phrase show up in these notes? That needs to be a red flag. No matter what the language is it repetitively used within the same visit note, within notes for the same patient, by the same clinician, by the same discipline? Then we need to have a conversation and say, you know what, this is not working well. This is leaving out critical pieces. It is not, you may think it's easier, but it's definitely not hitting the mark it needs to hit. What do we know? The CMS is not big on saying you're going to get denied because of one thing in isolation. That you walked the patient too far, boom, homebound status instantly combusted and we won't pay anymore. No. But we have a litany of examples of why we think we got denied. Well, a lot of times what we're finding is it's not the single element that's the problem. The fact is CMS repeatedly states that their determination has to look at the full scope of the patient issue, the entirety of the record. They keep saying this to their own reviewers. Then we have to look ourselves and say, wait a minute, if they're looking at the entirety, am I giving them enough to look at? Or am I just putting down the bare bones minimum and hoping that they will extrapolate from it that this is skilled, reasonable, and necessary? So what you see there in the visual about clinical documentation is not every single visit, I got to beat every one of these circles to death individually. No, I need to look at not only an individual note, but a body of work and say, are we not only within this discipline, but as a multidisciplinary team, creating similar messaging about why this patient is homebound? What is skilled, reasonable, and necessary about this care? Do we see evidence of clinician judgment? More than just continue per POC. Why do you think additional services are warranted? Do we see true care coordination? Or has it been more of everybody sits in a room and signs a piece of paper that says, I heard what you said about what you were doing, but we're still not on the same page in terms of what we're focusing the care? And again, back to that patient-focused care. Can we see by just reading the notes who this patient actually is? Could we identify it if we didn't have the name, rank, and serial number across the top on this entire record, not just the plan of care now, as Dee has used that example in other webinars, but on routine visit notes? Could I take the patient's name off, flip these papers around amongst individuals, and figure out which patient it was? Because if I can't, we really are not reflecting clear patient individuality. So what do audit findings show us? The reason we include this is sometimes as an individual agency, you may say, geez, how did we end up behind the 8 ball? Or this must only be issues in our organization. Or we've had external review and I think that, we just got the short straw and got a lousy reviewer who's really being picky about. No, unfortunately, insufficient documentation is a common finding. And again, what always concerns me is when Dee and I audit organizations and send back the report, rarely is anybody shocked. I mean, and these can be some pretty substantive deficits, especially when you're talking about therapy risk for denial and the reimbursement implications. And we consistently hear, yeah, I kind of thought that was off. Wait a minute. We need to get ahead of it. We need to make sure that we have all of these pieces clarified, because finding deficits in each one of these areas is all too common. So how do we get unstuck? Part of it is helping all the clinicians, regardless of discipline, understand their responsibility. I know people don't like to document. That is abundantly clear. But it is the means by which we communicate to third-party payers. And this is not an adversarial communication. If someone else is going to pay for these services, that someone has the right to know what's going on. Just like if you were having work done on your home or on your car and people were not giving you information, just handing you bills and saying, pay me. Well, how long did this take? What did you do? Just says at the bottom the total. It doesn't have anything on it. I don't understand what you're expecting me to pay for. I'm not arguing with you about the payment. I'm wanting to understand what I'm paying for. And that is a responsibility issue. So we know as a clinician in home care, we have responsibility to regulatory agencies. We do. Regulations apply. I need to know what they are. This kind of I just take care of patients and it doesn't really matter to me is unfair in relation to any setting you're working in. The payer expectations are clear. If we really don't want to have to deal with third-party payers, then we don't go into a model where we have someone else paying for it. But I can imagine that if we had all of our patients, if we set aside the financial concern piece and just say our patients were going to pay us cash for everything they did, do you think they'd have questions about what's going on and why it was getting done? Anybody who's paying for services would. But ultimately, the licensed clinician has a duty to that licensure to follow these expectations. This whole idea that I'm a great clinician, I just document poorly. She's a wonderful nurse, but her documentation drives me insane. I'm a great therapist, but I hate documentation. Does it really matter what I put? We cannot keep allowing that disconnect. You cannot be an amazing clinician and a horrible documenter. If that's what is happening, then we've got to bridge the gap. Because if we really understand the fundamental concepts, how we provide care in our amazing wonderfulness should be translatable to the documentation. And this idea as a reviewer that you can't read it unless you have the same discipline skill set is ludicrous. I've seen it used far too many ways from one discipline trying to tell another discipline, you cannot possibly understand this because you're not the same discipline I am. Or reviewers saying, well, I don't understand what it is because I'm not a nurse. I don't understand what they're writing because I'm not a therapist. Okay, wait a minute. We're not helping this situation by adding to this dysfunction about who can look at it. A lot of this is, by virtue of operationalization, is can you read? Can you read? And I'm not trying to be facetious, because reading documentation is what we have to do, because it's either there or it's not. I can't read between the lines. I can't add it because, I hang out socially with one of these clinicians, and we're really good friends. I know she does good care, so the documentation is adequate because I know that her patients love her. We cannot do that. It's either there or it's not. So sometimes that changing papers across disciplines can be extremely helpful. I think it's very eye-opening when non-clinicians read clinical documentation. Yeah, okay, I'll give it to you that maybe some of the terminology nuances are difficult and they have to adjust to that, but they can pick up really easily when a clinician on admission decides to write their whole narrative, the narrative summary, and that's what the field's called, narrative summary, and what they write in it is patient was seen. That's it. I don't think you need any sort of degree to figure out patient was seen is insufficient. So how do we bridge that gap? Well, you can't talk about documentation and reviewing documentation without the risk of divulging into a litany of why I hate my electronic medical record. That if I just was back on paper, everything would be great. And when we work with agencies, and yes, they do still exist that are on paper, they think if they got computers, everybody would be fine. Okay, no. There's pros and cons to both. When we look at the reliance on the electronic medical record, they're going to give us choices. We can use this. This will be better. Yeah, we get standardization. We can probably read it a lot better because legibility improves. But we run a risk when there's too many check boxes that it becomes cookie cutter all over the place, that we're just clicking, and people are clicking things they don't really intend to work on just because it was really easy to click it, and we lose track of things, and it looks very generic and repetitive. Then we say, well, just give me back my paper. Give me more narrative boxes. Okay, we upped the odds of individualization. I would argue we've also increased the issues of legibility where we can't quite read it because it's really hard in some situations, folks still on paper, but even in the computer. I worry at times that EMRs have exposed some people's inability to spell, which doesn't really speak to medical necessity when I can't even really understand what you're saying because of the way it's typed in here. But clinician variability can lead to documentation chaos. People are putting things in different boxes. I like to put it over here. No, I put it over here. It's over here. I write it this way. You write it this way. I put it. And then as a reviewer, it's kind of like, I don't even know where I'm supposed to find it. I mean, if everybody puts it wherever they feel inspired to put it, then the review process becomes even more problematic internally of where do I find it? And externally, we all know the external surveyor is not always inclined to spend a lot of time trying to decipher where everybody decided to put stuff. They'll just glance at it, and if they don't see what they like, they'll start throwing denials on it. We see this as evidenced by when we get a denial that we're able to just turn around and say, hey, it was there, not where you looked, but over here. How do we get to that important degree of consistency? I would argue, as I believe Dee would, that we've got to stop blaming the tool and understand that documentation comes from within the mind of the clinician. The tool is just a mechanism where to put it. It is not what creates good documentation, and it's not what in and of itself makes bad documentation. I'd argue sometimes it makes it harder to document and makes it more complicated in certain situations, but it can't take the full blame of why we're having to talk about this. So what are those elements? I want you to keep in mind, we understand everybody's electronic medical record or paper tool has its flaws. And sometimes as we look at it, it doesn't have the nicest spot. It doesn't have a glowing, this clouds don't open and a beam of light necessarily descend on exactly an ideal place for everything on this list. We know that. But we must continue in the short term to ensure that these elements are there. If we as an organization don't have a clearly defined spot that says patient's response to care on it, then where in the record are we going to decide it belongs? So that we all know when we document where it should go. And then we continue in the long game to work with our electronic medical record vendors and say, listen, how we have this tool now never really worked all that great. We need it to do different things in light of the COPs, in light of how we understand skilled, reasonable, and necessary. The clear rationale for continuation of care can't be a checkbox that says continue per plan of care. Sometimes the choices we have in there, we say, well, that isn't probably the best choice. Okay, then don't use it. Where do we want this information to go? We need to be the driving force of putting these elements into the documentation. So when we look at this, we're back to ensuring repetitively, whether you're the clinician generating documentation or you're the reviewer or the educator in the organization, we have to keep taking people back periodically to what are the coverage criteria and the qualifying criteria. Okay? These are things that are big picture that often get only touched at orientation or if we get in trouble, but then in between it lapses. Are we very clear? We know what needs to be in here in terms of determining eligibility. We also know these things need to be looked at again at a minimum anytime we're going to continue care, especially going into a new certification. Do we have all these elements? Now, we see the 5 elements listed on the screen. What we want to focus on are 2 big ones that are directly impacted by the clinician: confined to home and need for skilled care. We're not saying as a clinician you're disconnected from the other 3, but those other 3 have elements of it, and you can see the word in all 3, physician, physician, physician. We have to work collaboratively with the physician in those other 3 areas, and very often we have office-based processes to help facilitate this. But those 2 in the circles are the ones where a clinician can make or break us from the jump in relation to what is going into your content. So I can have the best nursing assessment written in the history of the universe. I could have therapy content that in and of itself is so beautiful it makes Dee want to cry for joy. But if I mess up homebound status, we're going to have a problem. We know that is very often where a denial goes the quick route. It's like they didn't even bother looking at your skill issue. They looked at homebound, said you don't meet the criteria, and just chucked the record right from the go. Because if you're not homebound, you don't get to have services at home. You could still need a nurse. You could absolutely still need therapy, but you don't qualify it for in the home if you can't support this. What does this mean to an auditor? We have to stop with just the pre-billing scrub version of our criteria and criteria 1 and criteria 2 there. Yes, they are. We talked about it in illness and injury. We have this condition, okay, one or the other, and then we move over to the right side and say normal inability, taxing effort. Boom, they're done. Okay, this has been clear as day with respect to the surveyors and their absolute lack of tolerance for check boxes repeatedly showing up on visits. And for how long have we said that was compliant on our internal review? Homebound was addressed. Homebound was addressed. I saw the boxes. Turns out the boxes were insufficient. As a reviewer, you have to look at not just is it there in concept, what is the content of those elements? So when we look at confined to the home, we can have the presence of the element, okay, but what do we need to see underneath it? What are those patient-specific things? So yes, we see reference to the use of aid or assistive devices. Okay, so the question you need to answer, you need to be able to read out of someone's documentation are what aids, what level of assistance, what devices is this particular patient using? What do they need? And if it's a medical contraindication, if we actually have a physician restriction, then I can use this kind of pre-billing scrubbishness. I should make sure there's an order for that there's an order that supports that. But what is it specifically? Then we start talking about normal inability to leave the home, considerable and taxing effort. To me, considerable and taxing effort is a gold mine of ability to show patient specificity. Part of it, though, when we look at normal inability is can we see the context for this patient? What was their normal before, and how long ago was that? Yes, this sounds an awful lot like prior level of function. Yeah. What were they capable of doing before in relation to their ability to go out into the community? Was this someone who only went out occasionally for doctor's appointments to begin with? Was this someone who was out and about doing social and medical activities and visiting grandkids and doing all sorts of family events? Was this someone who basically was a homebody before and only went out occasionally? Yeah, we need to understand that in relation to their ability to leave home and how long has this been an issue for them? What is impeding their ability? Considerable and taxing. Well, what makes it considerable for that individual patient? What is unique about them that makes it different? Because if this was just kind of a generic considerable and taxing effort, I would argue anyone with small children is homebound. Anyone. They'd all qualify automatically. Because getting out of the house with a little kid is considerable and taxing effort. I'd argue people that have pets could take the same path. It's considerable and taxing effort to leave the home. I got to put it up. I got to do this. I got to move it over there. Oh, that's it. Half the country suddenly just went homebound. This is why we can't just use those words in our documentation and say, if I say taxing, if I say considerable, if I say walker, that's enough. Is it? When this is such a cornerstone of defending our ability to provide services in this setting, we can't take it lightly, and we can't take it to just be little boxes at the top. Keep in mind, to address the elements, I don't necessarily have to put it in a box that says homebound. I don't have to put it anywhere that says, this is homebound statement. Can I pull this out as I read the documentation? Does it become clear as I read this nursing note, as I read this therapy note, why this patient has to have the services in the home? Why they can't just go out and get it? That's what you're looking for. So, Dee, we have a patient here, and I'm going to turn this over on you to get your thoughts, because I know you have some thoughts. But we're going to use our example of Mr. Smith, and we're going to go through these pieces, and then I want you to share your wisdom on where you think homebound might be coming through for this individual.
Sure.
So we got he's a 78-year-old male admitted to home health for skilled nursing, PT, and an aide. Oh, well, see, he's already homebound, Dee. It says he was admitted to home health. So we don't need to talk anymore. We have a referral, therefore by default he is. Yeah, we know that's not true. He's got a new diagnosis of pneumonia and exacerbation of his COPD. During the hospital stay, he had numerous medication changes with the addition of oxygen use at home. He lives alone in a one-story home. He previously drove himself into the community, ambulated without a device, and denies any falls for the past 12 months. Mr. Smith's PT evaluation reveals weakness, reduced balance, impaired gait with shortness of breath with minimal exertion. So I don't see the word homebound in there anywhere, but do you see anything that looks homebound in that description, Dee?
Yeah, well, using those queries that you had on the previous slide, what assistance and devices, it looks like he was previously independent, and now, he has a lot of weakness, He may be using a device temporarily. He has reduced balance. I'd like to see what the therapist wrote or what objective measures. And he also has oxygen that he uses, so there's some more equipment that he, can strap onto himself and lug around. Um, and uh, you know, the community mobility is pretty extensive from what we know in the literature. And so he's had this recent change, which is a flare up in his COPD, and he has pneumonia. So if you're asking me, homeboundedness, I think you've got enough information there to individualize it based on how Mr. Smith presents and show considerable and taxing effort, a very clear prior level of function, and and use some of the values like maybe his oxygen levels or his, how he may desaturate or become dyspneic after he walks certain distances that are not consistent with that prior level, or the quality of his walking due to that due to weakness and impaired balance. How that starts to make him more of a falls risk, with or without a device, which he didn't have to use before. So those are just some of my thoughts about capturing, needs assistance and considerable and taxing, and he's limited as compared to his prior level.
Well, and I think that's the key piece, Dee, is as we look at that kind of description, we say, okay, so how does that description of an individual end up when we just pick a box, taxing effort, or some of the phraseology that we see of, patient can't ambulate more than 10 feet. Well, wait a minute. That's not even what we found in the PT evaluation. It's really looking at the documentation with a clear eye as a reviewer. Do you see elements that capture what particular assistive devices they're using or what kind of assistance they need? Looking at what is preventing their normal level of activity. Why can't Mr. Smith just go back out like he used to? Why couldn't he just go for follow-up at the physician's office? And then, yes, you do want to see measurement, something tangible behind what is making this a considerable and taxing effort. Is it oxygen desaturation? Is there more specifics in the therapy evaluations that quantify what those limitations, what those functional impairments are that are contributing to this? So when you look at a homebound statement, you want to be able to see things that pull from that. They don't need to repeat everything on the previous slide. That's one of the things we're trying so hard to avoid. We don't want to make it so it just boils it down to a generic text box. We also don't want to make it where people feel like they got to repeat the entire evaluation statement again. You don't. But how do you pull together? How do you take pieces of information? I think that is the critical challenge we have with any documentation, is we tend to put bits and pieces of information in their different corresponding areas in a note or in an assessment, and we don't connect the dots. We assume someone else will read it and be able to figure out why Mr. Smith is homebound. Well, maybe another clinician would, but how can you avoid that concern about individualized interpretation or whoever might review this, and basically pull those pieces together in a way that would convince you as the reviewer, yes, this person is homebound. And sometimes it's difficult. If you're reading it and you don't see it, we need to have that internal conversation. We need to use the questions that Dee's provided in this presentation to facilitate the conversation to get us unstuck. By blind eye passing things through, or by being uncomfortable that that's not my discipline, or that's not really or we've worked together for years and I know she's a really great clinician, we need to get past that, because we know when it comes to a real life outside review, especially from individuals that are trying to take your money, there is no free pass. So we don't need to turn into, the concern some have about the documentation police that are out to get me. But how do we work collaboratively? Because the elements are there. We just want to make sure we're pulling them together correctly. And when it comes to pulling elements together, skill is the next big one. So homebound, we know that's a key issue. We're called home care for a reason. But the skill is one, I think, where we are our own worst enemy as individual clinicians. And a reviewer can be hugely instrumental in helping us to see this. Not as an ego boost, not as a rah-rah cheerleading service, but as a realization that when you are providing skilled care, it is not the tasks in and of themselves. It is the thought process, the decisioning behind this. It has come from education and experience and training and years under our belt doing this in this setting, in different settings. It goes into the home with that clinician and it leaves when they leave. Not everybody else can just do this. And the quickest way is if you're reading the note and thinking, I could do that, and I'm not even that disciplined. Or the daughter could do that. Or, oh no, here we go. They wrote in the note that the daughter is doing the same thing on days that this clinician doesn't come. If she's doing the dressing change on Monday, Wednesday, Friday, and the nurse comes and does it Tuesday, Thursday, and the documentation reads it's the exact same task, why is a nurse doing it on Tuesday and Thursday? I'm sure what nurses are going to tell me, because that isn't all I'm doing. I'm doing this and the other and educating and checking. Good. The rest needs to be there then, because if it's not, and you're basically saying the nurse and the daughter are doing the same thing, that's not skilled care. The staff are walking people to the dining room on the days the therapist doesn't come. So the therapist comes and walks them to the dining room. Okay, we have to make sure we're speaking to this issue of skill. And when we look at this issue of skilled need, there's a series of questions you can use. Because sometimes you can read what it says, must require the skills of a qualified nurse therapist, blah, blah, blah. Yeah, okay, we know. We can read regulation. But how do you apply it? So when you're looking at the need for skilled care, what is the deficiency or impairment the patient has? And this is why measurement is critical. Impaired, limited, decreased. Observational, yes. Quantifiable, not so much. What specifically are the issues for this patient? What care can only be provided by the skilled clinician due to its inherent complexity? That, I think, is the toughest question. We don't think what we do is that hard. We get very common sense about it. Like everybody would understand. I know how to, I adjusted the walker. I set up a pill planner. I did that. Yeah, that took skill. Think about the training it took. As a reviewer, again, if this doesn't look complicated, if it looks like the same thing happens every visit and really reads as though all therapy is doing is counting ever-increasing gait distances or reps of an exercise, that doesn't look complicated to you, it's not going to look complicated to somebody who wants their money back. And why can't a layperson carry out this education or intervention? This issue of what we're teaching, as a reviewer, we've got to be paying attention to when it slips to phrases such as caregiver ed, unless they're all named ed, I don't know. I've seen it documented CE. Wow, we can't even spell out caregiver education, which those two words by themselves aren't specific enough, but can we please not do an abbreviation? Verbalized understanding. Oh, great. They repeated back what you said. How do you know that what you taught was really understood, that it's really going to make that kind of impact, that it really requires someone with expertise? And this is where the whole, but they don't have a caregiver, and so I'm going to keep seeing them. I'm going to recertify them. You need to keep him for therapy because his wife just can't do this. Does not make stuff skilled. If you could teach a layperson to do what you're doing and comfortably say, I am so glad they're here because they can do this with the patient, then it's not a skill. If someone else can do it exactly to the degree and as efficiently and effectively as you can, and don't take efficiently for it, it's just faster for me to do it than the daughter, so there you go. No, it has to require my skill set. So, Dee, I'm bringing you back because we have the same issue here with respect to Mr. Smith. I'm not going to reread his description, but what about what we see would indicate a skilled need? And I know there's not enough objective measure in here for you, the Empress of Test and Measures. I love when you are, that's I'm calling you that. I called you that on the call. You weren't even on today. So if your ears were burning, I was talking about that earlier. But what about this? Just if I was reviewing a record, what kind of things would make me think skilled as opposed to, yeah, the neighbor kid could do this?
Well, first of all, he's had a recent change in his condition, okay? And so my question is, what does he understand about his disease process? What does he understand about what degree or what severity or complexity of the COPD? I'm not saying that he brought the pneumonia on himself, but we know that he's community mobile, so he's engaging in the community. He also had a lot, it says there, he had numerous medication changes with the addition of oxygen. So, I'm sure he got a lot of education about the pills and why they were changing this medication for that. But you got a guy with a chronic disease and a new problem sitting on top of it with the pneumonia. who was previously independent. You mess up all his meds, you change it. He lives home by himself. I see a real need for skilled nursing to explain why these changes, what he needs to look for, how he needs to take these, and the role of oxygen, which is probably just a cumbersome external gadget that he has to be connected to, right? So we have to talk about that. We have to talk about when it's appropriate. Is he using it the way he's supposed to, as needed, PRN, at night, or continuous, right? So then when we talk about therapy, I'm looking at the skill of, this is a guy who took care of himself and entered the community. If he's feeling weak, he has a shortness of breath with exertion, maybe he's desaturating. ADLs require a lot of metabolic activity to get himself up, washed, dressed, make his own meals, do the things that he did before. Are we teaching energy conservation? Does he understand how to pace these exercises so he's not making it harder on himself? Does he know when and how to use the oxygen? What could be more physically demanding for him, right? And is he safe moving around the house? Is there other ways that we can strategize, or that can be set up to support him during this recovery phase until he can bounce back to that prior level or very close to it? So I see room for a lot of unique things in his home that we don't have a caregiver, what he has to take accountability and be accountable for and be responsible for because he's there by himself. What kind of education and training? What is the individualized prescriptive exercise program that we're going to do for peripheral muscle strengthening, and how are we going to optimize his aerobic capacity with this underlying chronic disease that is always going to provide some sort of barrier to based on the severity of it, to full capabilities aerobically. But he did function before, so we have to kind of evaluate that in terms of these conditions, and as the pneumonia resolves, the long-term management of his COPD and the effects of those medications on his performance. What are they going to help him do? What are they going to maybe provide artificial restrictions or barriers to? So I see a ton of opportunity for skilled nursing, PT, OT, maybe a social worker, all involved in that. But I have to base it. I have to go in with an idea of what I'm looking for that I have to speak to so that I can make sure that I capture that in my documentation. Is that what you were looking for, Cindy?
Yes, because I think when we look at these examples on the slide of capturing the deficit or impairment, looking at the inherent complexity, I think sometimes we've thought that a diagnosis covers this. So we've behaved as though, well, obviously, if they have diabetes, they need a nurse. Mr. Smith has COPD. So if we just talk about that, we have it listed as a diagnosis, then that's why it's skilled care. There's people with diagnoses very similar, just in listing, that have COPD, that had recent pneumonia, like Mr. Smith, that don't need a nurse. They don't need a therapist. Their recovery from those disease processes, their other comorbidities, their social structure, their caregiver situation can be completely different. They don't need a skilled service. I think as medical professionals, we thought our documentation is all going to be taken care of because this diagnosis label is on this individual, and it by default means they need these services. What Dee broke apart was, yes, diagnosis is part of it, but it's how that was impacted by his medications, his living situation, the medication changes. All of those things coalesce to speak to unique need for skilled care. We cannot keep approaching documentation review as though let's check what the diagnoses are. Yep, that makes sense that they're having care. They don't define care. So there has to be that next step of what about this disease process or elements, what is it impairing, what is it causing challenges for, what is the complexity of education. This is why nursing, I love you dearly, but the documentation is just choking on never-ending med teaching, medication education that doesn't really speak to what specifically, what about it, how do you know if he understood, at what point is he grasping some and not others, are some of these about when to take or others about the impact of these medications, is he struggling over the side effects and so he doesn't want to take some of these medications. That's the stuff you talk about when I see you in the hallway and ask you about Mr. Smith. But we boil it all down, get to a note, and put med teaching. And it appears the patients don't get any smarter until the discharge visit when they suddenly know everything and are dischargeable. and no longer homebound even though we never wrote down they left the house. So we really need to be thinking about that specificity. And as a reviewer, you can help us because we think we put this in here. We think we made it very clear. But if you're reading it going, I'm looking at this list here, I'm looking at these notes, I don't see it, I'm not doing it to be punitive. I'm just trying to help prop the mirror up so the clinician can look at it and see, do I see me in these notes? Or does it read like a bunch of things the patient did and I happen to be there, I guess, observing? So when we look at this, just a question to the group before we move forward. When we think about documentation issues that are the top reason for denial of home health claims, so what is driving this issue of denial? Would you say it's OASIS-specific issues? Is it homebound status? Is it medical necessity? Or is it concerns about not having a particular qualifying diagnosis? Well, interestingly enough, the primary reason remains what it has for a long time, which is medical necessity. So we say, well, wait a minute, what has that got to do with it? Well, Dee, I'm bringing this up now for you because many people probably think, has it been, I've been stuck in 3 webinars, and we're going to say, wait a minute, sometimes what we're really trying to get at is it reasonable to be in webinars this long? Sometimes it's absolutely necessary. So how do we equate this? If we're saying medical necessity is where we're getting hit, wait a minute, but we have very sick patients. We have OASIS that says they have a lot of complications. So if we have those other bases covered, wouldn't need be taken care of by default?
No. Remember, these are the 3 qualifying criteria. We talked about this in webinar 1, right, along with skills. And so just as a reminder, from an auditing point of view, when we look at charts, with, we have our auditing cap on, we're thinking, worst case scenario, right? We want to make sure that defensibility element is there. We look at, does the amount make sense, and is the care indispensable? Have we made a case for that? So how do we get to auditing? How do we find in the documentation that operationalization, if you will, of reasonable and necessary? Because basically what we're looking to establish is that a patient's overall medical condition, without regard to whether the illness or the injury is acute, chronic, terminal, or expected to extend over a long period of time, should be considered in deciding this, but it should not be the only thing that we use. I once, just going back to your comment, it keeps coming into my mind, and it was fairly recently with a therapist who did not understand my auditing feedback. And you know me, Cindy, I can be a copious note taker, about specific examples. And there was this patient with ovarian cancer, and he said, I said, what is it about ovarian cancer, about this patient that makes them, need your skilled services and need it in the home? Well, why is that the case? Because he was having issues with the need for therapy, establishing skilled, reasonable, and necessary, and meeting that eligibility requirement. And he said, she has ovarian cancer. That says it all. And I said, in my mind, I'm saying that says very little about it. Well, think about it. The medical diagnosis is part of the picture, but we have to look at the entire presentation of that patient, understanding that it is not simply a diagnosis, but that overall condition. And so consider kind of answers to questions such as, what kind of interventions are appropriate for this patient, right? Are we doing the kind of things that we know is consistent with current standards of practice? What education or training needs to be addressed? In other words, just think about our Mr. Smith. Does he have a full grasp of the impact of his disease process and how he may be contributing to exposure to these exacerbations or to coming down with pneumonia? What is he doing to try to be accountable and attentive to this, right? What about why are those interventions and education required? Where is that gap in knowledge or understanding? We talked a lot about this in some of the flow diagrams that we discussed in webinar 2 related to care planning and building that care plan and care coordination. And what is it that you think is reasonable for the patient? right? So if you're looking at reasonable and necessary and you have a very clear, objectively quantified levels of impairment or gaps in knowledge, specific knowledge that is integral to management, self-management of these disease processes or remediation of risk, and you think, this is something they should be able to do, how do you get there in between? What are those pieces that you need to provide? The structure of the program or the actual carry out of the program? And if you actually have to carry out the program, then don't document, like Cindy said, reps and sets. Don't document number of feet. Document those things that it requires the trained, skilled judgment and eye and knowledge base of a clinician to handle, right? So those are the kind of things that we have to think about. So let's look again at Mr. Smith. We already know who Mr. Smith is. So when we're talking about reasonable and necessary, related to this gentleman who was in the hospital, right, had pneumonia, exacerbated his COPD. During that stay, he had medication changes in oxygen. We've already talked about homebound, being able to generate a homebound question. We've already been talking about the skill and how we find opportunities. Let's answer some of those questions now from the previous slide related to reasonable and necessary. Do you see the opportunity where this could be, it is reasonable to provide skilled intervention? So Cindy, I'm gonna turn about fair play. I'm gonna pull you back in a little bit and say, where's the reasonableness of having home care at this time? I mean, if you were going to answer that question, why Mr. Smith? Why now?
Well, if we look at, I would start looking at the PT evaluation. If we're looking at reduced balance, impaired gait, his dyspnea issues that are limiting his ability to get out, he has some medical conditions that don't appear necessarily stable at the moment. New diagnosis, med changes, so on and so forth. So it doesn't seem reasonable to expect him to just go to physician follow-up appointments to take care of it. It sounds like he's going to need more intensive one-on-one services, not to the point where he needs to be in a skilled nursing facility to be managed, but where he's not really in a position to easily go out of the home should he need medical attention. And based on the combination of things going on, he needs skilled individuals to work with him to get him kind of over this hump now that he's back home.
Yeah, and because of that weakness and him being previously independent and him not having any dedicated person to support him, he gets tired pretty quickly, and so his ability to get where he needs to go for this care, whatever it is, and then be able to participate it and get home and still function on his own, take care of himself, get meals, and that could be extremely challenging. And so I agree with you. This reasonable and necessary, he's had a recent change. He has new medications. He has a verbally reported drop from his prior level of function. And to boot, we did some standardized measures, and there's no way that a person with recent pneumonia at Mr. Smith, a man of Mr. Smith's age, shouldn't be able to demonstrate this kind of balance and this kind of basic lower extremity strength to make him safe and able to get out. And so when we're doing, we're using that information to substantiate our decisions. That's not saying we're not making good decisions. What we're not doing, and we're not getting to that. I think every therapist, every nurse would make these decisions. And we do that because we see these patients being treated on the regular. The problem is we're not documenting well to these specific elements of reasonable and necessary. And so when we look at auditing of reasonable and necessary, we should look for documentation that captures those unique interventions that are specific to the patient, that address their defined or captured impairments, right, from what we should expect or what they used to be able to do. We need to make sure that we are identifying that our training and our education and our programming that we provide is very specific to those knowledge deficits that this individual has, whether it be about an exercise program or it be about a disease process or it be about a medication. And we need to make sure that we have a very clear, picture of that house on the hill, if you will, what that expected outcome is going to be. Is this individual, have we provided the training, the instruction in the exercise program for strengthening or optimizing his aerobic capacity? Have we provided it in such a way that it is going to support, that vision of getting him to that house on the hill, right? Getting him to that outcome measure that we're looking for. Those improvements from the baseline OASIS data set items and impairments that were quantified through objective measure on the evaluation. That's simply what we're trying to do. And that's how we establish reasonable and necessary. And so fundamental to this in auditing is finding that clinician's judgment or opinion or the assessment. And I think I've shown you this slide before, but if not, forgive me for thinking that I did. I love this slide. I love it mostly because a PhD RN has pulled it together, but mostly because it breaks it down into a very easy diagram. What we observe, what we reason, and what we think about that is our clinical judgment, okay? Everybody has a judgment, right? Everybody has an opinion about things. That's not what we're talking about. We're talking about trained expertise. And so this is what we're trying to substantiate. How did you get to that, and how do you document that? And you do it, you come to that conclusion or enlightened opinion or professional assessment following observation, reflection, and analysis. Those are the pieces that are extremely important. What feeds that observation and provides the elements for reflection and requires analysis comes from the factual information that we capture on our regular visits from the initial eval or start of care on, as well as the subjective information that is provided by the patient, by their caregivers or representatives. What is of importance to them, so that we can always keep this idea that I have to get you stronger and I have to get you more steady on your feet. I might do that for every patient I see today or this week, but I'm doing it for your unique needs. Specifically in this situation, and we factor that in to how we come to what is reasonable for this individual. And so, when we're looking for clinical judgments or we're looking for assessments, I've had everything be as free form to patient was seen, a 0 with a line through it, where absolutely there is no assessment or there's nothing to assess, I'm not sure, all the way to an SBAR format, which is a very structured situation, background, assessment, and recommendations. And honestly, I think providing a structure for synthesizing this information towards a plan is a great way to support interdisciplinary care plan coordination, and a great way to say, what is it that you're trying to accomplish and why does it require you? Okay, and so you can search for SBAR. You can get some great resources on SBAR, but just to give you an example, the format that you might see in a note is you basically state the situation. This is a very clear, what happened, why are we seeing this patient, why is Mr. Smith being seen? Had an exacerbation, new diagnosis of pneumonia, new meds, now he's back home alone, right? Give that background information. You can dig a little bit deeper into if there's any complications or anything like that. You can talk a little bit about his prior level of function here and how he was able to function before this happened. Is it the first time it's happened? Is it newly diagnosed or recently diagnosed with COPD, or is he a chronic revolving door through hospitals at that time of the year, right, the flu season? Give your assessment. So based on all the information that we've gathered and what we know about this patient, this is what we think. It's almost like doing the verbal report. Think about if the patient said right at the end of the evaluation, so what do you think? What's your opinion? Am I going to live? Right? Isn't that what they sometimes say jokingly? Or, what's the verdict? Do you say these crazy catch cliches or phraseology that we end up documenting? Just try reading that out loud or thinking that out loud in your head as you go to write it. If the patient asked me, would I literally stand in front of them and say this? And if the answer is no, then write what you would say. And sometimes that's hard for clinicians because it's become so automatic with us. And then finally, what are your recommendations? Be specific on this. right? Yes, it says advise the physician, but this is part of that care planning and care coordination and part of the interdisciplinary team. Be specific in what you're trying to accomplish because that also demonstrates skill. I noticed these were the problems, these are my plans, this is specifically how we're going to get there. Starts to really take shape and start to show a patient centeredness. Okay, and really support or provide some robust information that that a reviewer or an auditor who's looking to recapture funds or deny claims is going to be able to sink their teeth into and say, yeah, I don't have a lot to work with here. I see enough that I think they get it. And so it's really not providing the care towards any regulatory body, but the care towards what we know clinically is indicated for the patient, but documenting towards third-party requirement needs. So a sample SBAR admission note might read something like, the situation would be the patient is referred for home health care services due to what? And just fill it in. And providing these sort of queries and these sort of templates to answer this question or complete this statement with as much information as you need as succinctly as possible is a great way to help queue up or tee up, if you will, the kind of documentation that anybody could understand. The background is the patient was recently discharged from the hospital, let's say, following a CABG, or in Mr. Smith's case, following a new diagnosis of pneumonia on top of an exacerbation of his chronic COPD. The past medical history includes whatever's relevant. The assessment would be objective findings, show a risk for rehospitalization due to maybe the fall risk assessment, the deficits in meds or the new meds maybe for Mr. Smith, the instruction needed, the fact that this patient lives alone and lacks any external support but was previously capable in the community. Maybe he's verbalized some concerns over how tired he gets, how quickly, and he's having trouble getting up and doing the basics to get himself washed, dressed, and fed every day. And participate in home care services. And your recommendation would be based on, this, or the admitting or the evaluating clinician recommends what? What discipline for what? And maybe if it's nursing admitting, the therapy, we want to see you evaluate more quantifiable information about his reduced aerobic capacity, lower extremity strength, and falls risk related to this balance that he ties to this weakness that has set in since his hospitalization. I don't know. I know that sounds like a lot of words, and it may be 3 or 4. It may be a couple paragraphs, but it's a very good summation of what's going on. And so when you pull that together on the individual members of the interdisciplinary care team, then you can collate that information and look for that fluency of documentation that we spent a good amount of time with talking about in webinar 2. You're looking to see that we're all painting a picture of that patient. We all understand those risks and we share them. We all understand that we're reflecting the presentation of the patient and we're capturing that in our information, and it supports that this is the right service at the right time and the right intensity for this individual. Okay? So care coordination, if there's a risk, everybody should know it. If you see somebody where he's had an adverse response to one of his bronchodilators, right? One of his inhalants, the new medications, and the nurse reports it. When therapy goes out in the afternoon of that patient, first, have they been notified? Second of all, is it going to affect his ability to participate, or should that visit be changed? There's nothing worse for me than seeing that a person had an event or had terrible, unusual pain or something out of the ordinary for them in the course of care, and the next person goes, and I always check the times on this, the next individual goes to see the patient, and it's like, okay, Groundhog Day, we start all over again. There's no complaints. There's no nothing about this, when it was a major event for the previous provider who just left the house 45 minutes ago. These are the kind of things that we have to make sure that we capture. And so understanding that we all have a responsibility to contribute, if you will, to that unique presentation of the patient. When we quality audit for care coordination, we want to see evidence of this in the record. okay? And so a great query is, as an auditor, and you as a, does the patient look the same, like the same patient? Okay, are they changing? And if they are we seeing that consistently captured? Are we seeing the improvements we expect, the stabilization, the learning, the carryover of it, the taking on responsibility, the resuming prior level? Is there just a consistent look to that patient, or does it sometimes look like this note is from another person's chart because any of the problems that were so well demonstrated by one discipline, all of a sudden the next discipline goes out there and they have nothing to say about that and it all looks hunky-dory? Those are kind of crazy opportunities where you have to say, I'm not saying that he didn't talk to you about different things. I'm saying you've got to be kidding me. He had a fall and you're not even going to comment on it? You know, he has this big egg on his head, and all of a sudden the therapist goes out, and after the nurse documents it and treats it, and there's no comment about it. That's a little bit nutty, okay? And so we have to stop and say, are we missing the forest, the trees through the forest? Are we so focused on, or are we so focused on our concerns that we don't address what's going on with this patient and keep them at the center of care? As far as the fluency of our documentation, remember all risk areas should be identified by every member of the team. We talked a lot about that and gave some great examples in the in the second installment of this webinar series that you can refer to. Think about it in this patient-centeredness model where we all understand and share and comment to and address within the scope of our discipline-specific skill set what is reasonable and necessary to remediate risk for rehospitalization. All right, and if you want to make that a query, what are you doing? What is therapy? What does this care plan do to address the risks identified in the OASIS or the risk for rehospitalization, which impacts our outcomes, right? And makes us a good post-acute partner for the continuum of care. Looking at patient-centeredness, we've talked a lot about the International Classification of Functioning Disability and Health, and I've included again for you a copy of that diagram that makes sure that we don't just focus on those health conditions and how they impact body structures and body functioning, but how they limit an individual's activities and restrict their participation. Answer the question, how is your patient's activities changed by this? What are they no longer able to do that they should be able to do, or what are they at risk of losing if we don't stabilize them through your intervention? Right? Those are great questions. And then we have to frame it up within the context of that home environment and those personal factors such as their motivation, their cognition, their support system. Okay? Remember, there are no limits on goals, but sometimes these checkboxes of goals that are simply goal phrases that really need to be individualized to the patient are unacceptable. Please don't start looking at goals and throwing them out because you have some general guidance that said don't document more than this many feet, or don't comment on things that relate to this. Remember, it all is established based on that that what is usual and required for that patient. So have a good prior level of function somewhere in the history so that we can make sure that when we're writing this guy is going to walk for long distances, that it's supported and it's necessary for him to regain his independence in living alone in a private residence. Looking at key elements of goals. I really like this slide. I really like this acronym, SMART. I love doing goal writing workshops for this reason. Nothing makes me happier, and Cindy knows, when I can get a nurse to write a great therapy goal and a therapist to write a great nursing goal, because it really breaks down all the magic and all the smoke and mirrors and all this idea that we can't use this information and build a template, because we can. And so remember, goals should be something that if you take all personal or patient identifying health information off of the record, and heck, you take everything off the record but just the goal statements and put those in front of the clinicians. Give the therapists, give the nurses the last 3 admissions, the last 5 evaluations that they did in the last week, and say who is who. And if all of these goals look the same and nothing is both measurable and meaningful to the patient, they can't identify identify who it is, chances are a reviewer is not going to see that patient individuality captured, and we're not going to be establishing the level of defensibility in our documentation that we're capable of. So just as another knowledge application here, I have a quick multiple choice question for you. So Cindy, you can jump in with this. Which of the following is a well-written therapy goal for your home health patient? And I chose therapy because a lot of reviewers are not therapists, they're nurses, and they say, well, we don't understand, we can't read that. It's written in the English language, and it should make sense if you follow that SMART acronym. Is it A, the patient will be safe and independent with a lower extremity exercise program for 4 weeks? B, the patient will demonstrate improved endurance as evidenced by the ability to shower independently times 2 weeks? C, the patient will demonstrate a 30% improvement in leg strength using an objective measure, here the 30-second chair stand score, to get back to within normal limits for their age and gender so that they can go up and down the steps in their house to access their bedroom and bathroom in 5 weeks? Or D, the patient will increase their balance as evidenced by a score increase of greater than or equal to 4 points on the Tinetti times 6 weeks. So Cindy, what do you think? Which of those do you think hits all those SMART in the goal statement that is both measurable and individualized in meaningfulness to the patient?
Well, I'm sure, Dee, people will just look at it and instinctively say, well, C is the longest one, so it must be C. I think if you look at all the goals, piece by piece, I think A has fallen victim to if it's a therapy patient, they have to have an HEP goal. There has to be one goal that talks about HEP. I've never really understood why becoming independent with an exercise program would ever be a patient's goal, and it doesn't speak to what the functional relevance of this is, and is this an exercise program we intend this person to keep doing every day for the rest of their lives? Because if becoming independent with this exercise program kind of implies, I guess, a lifelong commitment to doing it, so it doesn't really hit your SMART elements. The second does reference a specific activity about showering, but improved endurance doesn't really have a quantifiable piece to it. You don't really know what improvement you're trying to go for and how much of an improvement you need, because a very strict external reviewer could say, well, if one of your notes improved them just a little tiny bit, then I could say your goal is met because you didn't really give me parameters for improvement. And the last, I think, tends to mystify some reviewers the most because we have a Tinetti score in here, and therefore it must meet the criteria. But when you look at it, it's increasing it by 4 that does what? I mean, is this an increase by 4 that is a categorical or meaningful change, or is it what you and I have seen in documentation, Dee, where that goal corresponds to a baseline assessment that said the patient's initial score was 0? Well, 0 is a terrible Tinetti score, and 4 isn't all that much better. So I think that, C would be where we gravitate instinctively in this session by its length, but I think we need to also look at it and say what it really is what would traditionally be viewed as essentially 2 or 3 separate goals actually being pulled together in a way that as a reviewer of any discipline, you can understand that there's an improvement in a measure that's tied to a function, that there's a time frame to it, where I might not understand exactly what a 30-second chair stand test is, but by using the SMART template, I can find those. So maybe I also will not see as a reviewer 5 goals, 8 goals, 10 goals on every patient. I might see 2 or 3, but if they are as comprehensive as this, following the SMART format, maybe I only need that. I don't need a bunch of phrase goals. I don't need the mandatory home exercise program goal just sitting there. It needs to fit so that it makes sense why this person's being seen.
Well, absolutely, Cindy, and using my philosophy, I'll have to shorten up C. I just kind of went a little crazy on it, but usually I try to make all my answers, my choices, about the same length so we can eliminate that. But think about it. If you took off patient identifying information, would you know who needed the exercise program? You might have had all 5 people that you evaluated that needed strengthening and needed a program. No. B, would you know, maybe, if you're an OT or you're working on ADLs with people, you might have all your patients have ADL needs, and they all need to become more independent with showering. Maybe improving the endurance, but it still is not very quantifiable, like you said. C, maybe I'm doing strengthening. Maybe I'm using the 30-second chair stand for all of them. But I have that one patient who has his bedroom upstairs and needs to go up to that bedroom, so I know exactly who that is. That captures that unique meaningfulness of the patient. And D is very similar to A. We may use the Tonetti, but we may not be able to identify it because we don't know what that improvement in score, that categorical change is going to actually, how it's going to impact that patient's functioning. So I'm right there with you. And so looking at it from the perspective of, can you see how you're going to capture that goal is met specifically, and then what it means to the patient when they either achieve that through improvement or stabilize that and are able to maintain this ability. How is that going to affect them in an outcomes sort of mentality from a functional perspective? Okay? So let's go on and actually look at what a review might look like. So this is a form that I use, and honestly, I share it with organizations. I've updated it several times, but this to me, if you, like Cindy talked about at the beginning, this billing audit sort of mentality. Is it there? Isn't it? These ideas that your audit forms are yes, no, NA are inappropriate, and they're not going to be able to hit the quality components that you're looking for in your documentation. So that being the case, this is a form that I've developed that provides you the auditor's information, who did the eval, the type of visit that it was. We touch on that eligibility requirement for homebound, right? And then we touch on, did we capture something subjectively from the patient? But when we get to our skilled, reasonable, and necessary, that's when we move into the defensibility for the care that's provided. So let's start at the top. Under homebound status, we don't technically by law have to put a full statement every time, but we should infer at some point why we are continuing to provide this care in the home situation. From a therapy perspective, I like to capture and I like to look at that assistance and considerable and taxing effort. Now, maybe it's medically contraindicated for nursing, or because of psychological conditions, right, or cognitive functioning, it could also be medically contraindicated for that person to go out. That may speak more to OT, speech, or nursing to a certain extent. I'm not saying it does. I'm just saying these would be examples. So answering the question, why shouldn't a patient go for outpatient services? Why can't the patient go to the doctor's office to have that wound care dressing changed, nursing? That's what you want to know. Why do we have to bring the service to the home? How are we operationalizing that homebound requirement? Subjectively, we want to know what's up or, what's changed since the last time we came, what's going well, what's not going well. We're not simply reporting, I have no pain or I have no comment at all. So any current issues or complaints or concerns that arise since the last time we were there. Has there been any events? Has there been any functional changes, good, bad, or indifferent, falls? So for example, in this situation that we're going to follow all the way through this note, the patient reports she's been able to walk up and down her 5 steps without catching the toes of her left foot on the step. Now, I don't know if that's from a foot drop from a back surgery. I don't know if it's the residuals from a stroke. It's regardless of what the condition is. Remember, diagnosis alone does not determine the need for service or justify the care that's provided. So this is what she tells me when I come in the house. All right? Looking at objective information, we want to be able to look at what objective measures may or may not have been included for assessment during that time, what education and training or what interventions were provided. So for example, if we're looking at any tests and the analysis of that information, maybe for this individual, for this note, we chose the Berg Balance Test, the Activity-Specific Balance Confidence, because we wanted to, we were working on her balance impairments, and so we were going to do an updated measure because we felt it was appropriate at this time, and we also wanted to look at her balance confidence. because she used to walk independent in the community without a device. When we're talking about the education and instruction that we were provided, let's say example I find in the documentation, the PT instructed the patient in delayed onset of muscle soreness, or DOMS, correct completion of both concentric and eccentric contractions with progressive resistive lower extremity exercises. I'm not listening to sets and the reps. I'm telling you what I did, what I spent my time doing, what took the skills of a therapist, what walked into the house with me and left with me, the magic that I brought that wouldn't have happened if I wasn't there. So that's what I capture, my contribution. When I look at the interventions, these are the ones that I participate in. I update maybe the program, but what are the ones that require my skill set, either due to the complexity of the patient or the complexity of the program? Right? So what I did, or what the therapist did at that time, is muscle strengthening for the length ankle dorsiflexion, remember catching that foot, repeated through PNF, proprioceptive neuromuscular facilitation, with repeated contractions in D1 flexion, followed by gait training with auditory and tactile cueing for left lower extremity foot clearance during swing phase of gait on smooth and carpeted level surfaces. So right now, did I do gait training? Did I do verbal cueing? Did I do TheraX? And what I documented is not just those general concepts or steps or reps or distance. I documented the intervention that required me, specific to what her functional needs were, that were going to help reflect or help her score better on those measures of the Berg balance test and potentially the her balance confidence measures. Right? That's what I did. Now, if I document nothing other than what you've seen so far in the quotations, I have a very robust defensible visit note. I don't know how it fits in the software, but that's not my concern. My concern is speak to skilled, reasonable, and necessary. So looking at assessment and plan for this individual, we have to, again, this idea that we just don't put anything under assessment, a zero with a line through it, or patient making progress towards goals. No. We're not going to do that. What did I leave this visit feeling? And my plan is not when am I coming back to see you. It's not a schedule. It's not a day or a time. It's what are we going to work on next. So as we capture this clinical decisioning and rationale, we may see something that states it is this therapist's professional opinion that it's appropriate to continue the maintenance therapy services. They're appropriate based on what? Based on what? Based on the progress she's made so far, the stability, the reduction in her falls risk, the ability to get up and down her stairs, to function safely in her home environment, or an increasing ability, or what's the analysis of the Berg score that I ran the test on, or the ABC, the activity specific balance confidence measure. Looking at the plan for the next visit, what am I going to do? If nothing changes and we keep moving along, doesn't always happen that way when I knock on the door and the door opens, but if it is, here is my specific plan. I'm going to go ahead and advance her progressive resistive exercises that I've left her with. I'm going to educate her on how to self-manage her rating of perceived exertion so I can make sure that when she's completing the walking component of the program that I didn't even touch on today, okay, I just worked on these other things, that she's going to understand how to pace herself, right? And my progress towards goals is that maybe I've seen this week, if I'm just going to provide a summary, that she now has improved her lower extremity strength from her baseline measure by 35%. She's now able to get up to 8 reps, so I'm seeing the strengthening in that leg that we want to see, that we've anticipated is realistic and for her and is necessary for her to function safely and independently. And she is currently at 80% of achieving that lower extremity strength goal. And so if I document nothing other than those statements, I have hit skilled, reasonable, and necessary and homeboundedness for this individual. Okay? And so I'm not saying that you're going to see it laid out that way, but there should be very clear guidance where we want to see assessments. In objective, we want you to speak to these specific elements. We want you to capture something that is relevant to the patient, that they said, that they commented on, that is a concern, that is a change. And providing those kind of queries to our individuals, to our patients, to our clinicians will really help them to start to standardize their documentation. It's not going to change the way we provide care. We are therapists, and we're all great therapists. In my mind, I've not seen, well, I've seen a few, but very few really bad therapists, Cindy. But I don't see good documenters of the care that we provide according to the regulations. And so with these queries, I'm hoping that it will help you as a clinician understand how to document that, and as a reviewer, being able to facilitate getting that kind of content into the EMR or on the paper system that you use. So Cindy, I'm going to turn it back over to you for any questions, comments, or to wrap us up today.
Well, there is a question, and it applies to the slide that's currently up, so I'm not going to move it yet. How would you address concern about the word assessment, especially in light of, the professional opinion element or the fourth bullet of updating the patient status? How does that work when the visit's done by a therapy assistant? Is that still what you would expect to see? I mean, because, sometimes there is, for lack of a better word, a turf war on the word assessment of who can or cannot use it. And I think sometimes it's an element of semantic issue, but people really do sometimes struggle with, are there boundaries on this?
Well, honestly, it is a semantic thing. We know that assistants cannot evaluate patients, cannot change care plans, cannot modify that care plan. That all happens under the evaluating or supervising therapist. In the context of this form and the choice of that, this is basically, what is your professional opinion? And every clinician, whether you be an assistant, a PT, or an OT assistant, or you're an LPN, basically you have an opinion about how that visit went. Okay? You can run tests and measures. You can't interpret them, and you can't alter the care plan based on the findings, but you can score tests. You can score a Berg or an ABC, right? And so you can say, this was the score. It is an improvement, or it is no change, or whatever from the last measure. The therapist should be communicated to the evaluating therapist. So at the end of the day, I would say, if you're looking for a query for assessment, or what is your opinion of this visit? How did it go? What went well, what didn't, what's going to drive the decision for the next visit or to discharge. You always have to be basing that plan for the next visit or plan to discharge based on something. What is that something? What if the therapist was sitting outside in a car and said, so, you did Mr. Smith's visit today. How'd he do? And they're going to have an opinion. Okay, so it's basically professional opinion. We call it assessment because that's part of the SOAP note, right? That's how we all learned it. But ultimately, it's your assessment of the visit. How did the visit go today? And so querying that, or making sure that there's some documentation. Patient now understands how to accurately complete these exercises. Patient now is able, or patient is ready to progress. Patient verbalizes an increased consult. I think the patient is making advances consistent with what we expected. However, there still are areas that we need to return and work on because we're not all the way there. Written in a professional opinion is of the assistant is critically important.
Kind of along those lines, another question would be, your thought on when you see the assessment and plan area of notes pretty consistently over the course of care, indicating that the plan is going the way we planned it. So we're not seeing any changes to the care plan, and visit note after visit note basically is saying that this is working, that we anticipate discharge per the original plan, that kind of language. And then in the last few days of the cert period, suddenly we're going to recertify and continue services into another episode. Do you think that causes any issue from the external reviewer side when the documentation indicates our plan, which was laid out for X number of weeks or X number of days, the whole time no visit indicated a need to change it until spontaneously at the end, all of a sudden the team is talking about needing a new cert?
Well, a lot of times when we set these plans, we build them into the episode. But to be honest, a lot of times patients need longer. I'm just saying, why wouldn't we just write? I'm not saying write goals, that are beyond like 12 and 14 weeks. I don't want to get into that, that nebulous area. What I'm saying is, if you have a patient that is really deconditioned, and on your eval you think that they may require an extensive course of therapy, that may exceed this initial episode, and may include a component of maintenance to ensure that they've achieved a level of stability before we discharge them. Simply saying that is okay. But when we say that everything's going and we expect, when we write discharge plans for when goals are achieved, we see goals achieved or said they're achieved, whether or not in reality they are, because I don't find either any measures to support that, or I find measures that basically contradict that in the documentation through the episode, and yet then we continue to research, we don't address it. Yeah, that is a major problem. And so my statement is, it's okay to, I say this patient, it is expected this patient will be able to have this kind of recovery to support a discharge, within this time frame. Expected, anticipated. It's not hard and fast. It's not a requirement. But I have a lot of patients that I know it's not going to simply be 60 days and you're going to be, running the streets again like you did initially because of everything that's going on with you. And so, we have to find a way of capturing that and at least opening up that possibility. We have to have a way of changing our discharge statements from, when goals achieved, when max benefit, to when patient is able to optimize functioning, consistent with a prior level of function or at an optimal level, maintain this ability for a significant period of time to be safe and independent in that home environment. Because there's a lot of factors that can influence that. And when those factors come up and when those things happen, they fall, they get a UTI, they have an unplanned procedure, an adverse response to a medication, they're not healing as quickly as we like, they've got to stay on an extra dose, or they've got to start another treatment that has a deleterious effect on them. We have to start to capture that and say, hey, this may impact the plan of care, not just keep writing, oh, they're humming along and don't see any problems, when in reality, the thing's going to, excuse my French, hell in a handbasket, right? But we're not capturing that. And so that's where that fluency of documentation has to at least start to be acknowledged, and saying, these recent changes in medication, or the fact that, they are going to remain not weight bearing due to slowed or malunion or delayed healing of this lower extremity fracture, potentially is going to compromise the initial anticipated discharge date. I'm not saying go in and rework the whole darn thing, Cindy. That's not what I'm saying. But we have to at least try to capture it. So I think when we have a language that sings like everything is fine and dandy, we're just humming along, and then it doesn't happen that way, and it comes out of like thin air, we're reserting, it makes no sense.
And I think, Dee, that is indicative of our pervasive hesitancy or lack of understanding about putting our professional opinion in the documentation, because when it is just task-driven, it looks like tasks get done, and then, oh no, we need another cert period, or oh no, it's another 2 weeks. And it didn't happen that it's rare that you walked in that one day and went, oh my gosh, the wheels fell off and I have to rework everything. But we do have opinions that say, my original plan of care, the time frame for this is my professional best guess. As the course of care unfolds, there may be situations where you say, as you just very eloquently did, this is going to compromise our original anticipated discharge. Putting that in proactively makes so much more sense than what appears to be no one thinks about this till the last 5-day window, and then suddenly, boom, all of a sudden we're talking recert, and then for some arbitrary rule, there's new therapy evaluation showing up initially in the next cert period, acting as if they weren't there before, building another plan that looked an awful lot like the first plan. When you lack the opinion context, this looks extremely confusing. You don't see the rationale behind it. It just looks like people just keep going to keep going. So I just wanted to hit that piece, because I know I think to me that's a very interesting place to look as a reviewer of those decisions to either extend care additional weeks within a cert period or a recert, to say, do you see the lead up to that speaks to decision making? Because there is that piece behind it, and we want to make sure that we're capturing that. So we thank you very much for spending time with us in relation to 3 webinars. I understand that a post-test will be headed your way. Oh, I could almost hear the groan from here. It's really meant to measure your knowledge, but I think the best test of your understanding will be in your documentation going forward. Not because we think your documentation is horrible and Dee and I sit in an ivory tower and poke fingers at people. We believe, as Dee has said, that the majority of care being provided is exceptional, on point. The patients are doing better. You're doing a tremendous job. But you are doing an equally tremendous disservice when documentation looks like their neighbor could have done it, the daughter could have done it, the patient didn't need it, and we get mad. And yes, sometimes it's a misunderstanding, but very often it's we've left gaps, big gaps, that allow people to say, based on what I'm reading, I don't see it. And to internal review, we need your help. Not in a finger-pointing way, not in everybody's mad at everybody way, or just tell me what you want me to write then, but how do we work collaboratively to get that objectivity internally so that we never have to go down the road of talking for hours and hours and hours about documentation again, because I do suspect that is probably your primary objective. Thank you very much for your time. You have our email addresses should you choose to use them in the future, and we wish you a great rest of your week.